I'm Giovanna Mbezi, and welcome to the LACNETS meeting for May 2017. We'd like to welcome all of our online viewers as well for the live stream. Thank you for tuning in, wherever you may be in the world. We are here in Beverly Hills in the wonderful Tower Cancer Research Foundation, and we want to thank them for this lovely venue today. And I have a few announcements before we get started with our speakers today. We have two amazing speakers on a very popular topic of the cost of cancer care and medical billing and insurance. But first I want to mention that next month, June 24th, we will be having our annual conference. This is the 2017 annual NET Patient Education Conference. And this is an annual event we do with lots of speakers. It's a full day event. And this year there have been so many announcements and FDA approvals and pending approvals. It's a lot to keep track of. So this is an excellent time to come out and meet the doctors in person. If you've been calling and getting a phone prompt, press 1 for this. This is a time you can walk right up to the doctors and ask your questions and introduce yourself. It's also a time to meet other NET patients. And we know with neuroendocrine cancer that sometimes talking to other patients is the best resource for you to learn about what's going on, and talking to someone who's actually had a treatment you're considering or had a procedure you're considering really can go a long way. We have some excellent doctors from City of Hope, where the event is being hosted, which is right next to in the Pasadena area, and UCLA and Cedars-Sinai and the NET Research Foundation are all partners this year in our presentation. I'd also like to mention that Leanne Burns, who is a nutritionist who's worked with Dr. Warner and Monica Warner for many years, Leanne is a specialist in nutrition for neuroendocrine tumor patients. And she will be there from New Orleans. We also have doctors from the East Coast and researchers, so it's really going to be a great event. It's free, and June 24th, so please RSVP for that. And I wanted to mention there is a event happening in Denver, so the SNMMI, let's see if I can get this right, the Society for Nuclear Medicine and Molecular Imaging, is an annual event that happens, and last year was San Diego, this year it's in Denver. And our wonderful advocate, Josh Mailman, from the NorCal Carcinoid group, has once again organized an event for NET patients. If you want to come to Denver, I would recommend you go to the snmmi.org/PED, Patient Education Day. And is this on our screen? Yeah. So this is June 11th, and you'll see some familiar names on here with Thomas Hope, Dr. Thomas Hope from UCSF, Emily Bergslin, Lisa Baudet from Italy, but now in New York, who's a real expert on PRRT, and Josh Mailman will also be speaking. So if you're inclined to spend the weekend in Denver, that's an event that's coming up, and it's free for patients. You also will have access to the entire conference that they're doing that weekend. And two last things. There is I don't know how many people are aware that there's actually an app for neuroendocrine patients. Okay, so this is good we're talking about this. There is, through Self-Care Analyst, there is an app for neuroendocrine patients, and it allows you, among other things, to keep track of your symptoms, your medications, your appointments, how you're feeling. And they are doing a study, and so they're looking for some participants to help out with the study, and basically you agree to use the app 3 times a week for 12 weeks. There's some payment for that over the 12-week period. And if you want, go to this website. We will tweet this out as well and send it out on our email. It's Self-Care Movement, mvmt.com/research. Or you can email info@lacnets.org, and we'd be happy to let you know more about that. Lastly, we will be skipping July this year, and we're planning a really fun day together in August. It will be the first Saturday in August, and we'll be releasing details on that very soon. So, without further ado, I'd like to introduce our first speaker. Today we have with us Michael Gradski, who is well known in the cancer community for speaking about insurance-related matters. And he's the owner of Artist Insurance Services, providing employee benefits for arts and entertainment organizations and Medicare plans for individuals. He's also the principal of Aquarius Financial, a registered investment advisor firm. Michael has often spoken. I think it's been a couple of years since he's spoken for LACNETS, but we're very happy to have him back. And please welcome Michael Gradski. Thanks for tuning in.
Good afternoon, everyone. My main experience is with eligibility and enrollment for group insurance plans and Medicare. But along the way, although I'm not a patient advocate in the way that Martine is, I do advocate for my clients in just helping them be able to look up stuff. So I've learned a few things that are helpful for folks along the way. And what I'm going to cover today are just some of the basics of Medicare and individual health insurance, some of the changes and some of the enrollment aspects to that, and then quickly look at a little case study. Just recently came across my desk of just someone looking up the drugs, a Medicare eligible person who's changing from an individual and family plan through Cover California with cost sharing reductions, and then moving to Medicare and looking at some of the differences between how drugs may be handled in one particular drug with an individual plan versus the Medicare plan, and how to do some looking up of those drugs and what are some of the resources available on Medicare.gov and with a specific insurance company, whatever one you might happen to be enrolled in. So I'm going to start this little slideshow. So a little bit about Medicare. Medicare is the system for people generally who have worked about 10 years or more to attain the necessary credits to be enrolled in Medicare. The same is necessary for people who are eligible for Medicare due to disability. So Social Security Disability Insurance Program, SSDI. After a person receives disability payments for 24 months, then those folks are eligible also for Medicare, regardless of age. So Medicare is available for people both typically 65 and older, and also younger than 65, depending upon disability. With Medicare, there is an open enrollment period. There are various windows of opportunity for people to enroll, but once a person is enrolled in a Medicare prescription drug plan or a Medicare Advantage plan, the annual open enrollment is from October 15th through December 7th of each year. And that's a time when people can either disenroll or they could change a Medicare Advantage or prescription drug plan. Now, when a person first enrolls, that's a different situation. When they turn 65, there's a 7-month period where people can tell Medicare, Social Security, they want to start their coverage. If a person is not already receiving Social Security benefits at age 65, they have to tell Social Security they want to enroll in Medicare. If they're already taking Social Security retirement income, then enrollment in Medicare is automatic. You don't have to do anything. There's a monthly premium. This year, for folks new to Medicare, it's $134 a month. That gets paid to Uncle Sam. Unless a person is also low income and eligible for Medi-Cal, called Medicaid in other states, but Medi-Cal can pay for that Part B premium depending upon a person's financial circumstances. Let me just back up. Medicare Supplement plans. Get to the details in a little second, but in the slide that shows the 2 doors to Medicare, Medicare Supplement plans are designed to cover the gaps what Medicare doesn't cover. So like for doctor visits, lab x-ray, Medicare covers about 80% of the cost, and that gap is filled by a Medicare Supplement plan or a Medigap plan. So it's an optional plan that people enrolled in what's called Original Medicare may choose to cover those payments. If a person qualifies for Medi-Cal, they don't need a Medicare Supplement because a person eligible for full Medi-Cal, their premium will be paid, and that gap will be paid by Medi-Cal. For people who are enrolled in a Medicare Supplement plan, there's that thing called a California birthday rule. Medicare Supplement plans are regulated by each state. However, the benefits are determined by the federal government. So there are a bunch of different Medicare Supplement plans. It's kind of an alphabet soup. Medicare they love letters. But the same type of Medicare Supplement plan is exactly the same regardless of insurance carrier who offers that plan. A person already enrolled in Medicare Supplement plan can change to any other insurance company's equal or lesser value plan on the 30 days following their birthday each year without any health questions. So that can be an important thing for people who want to see specialists at different medical groups or even in different areas of the country. I'll get to that difference between door number 1 and door number 2 of Medicare, because that's the main difference. Door number 1, see any doctor who accepts Medicare in the country. No network, single payer, socialism, yay. So 4 parts to Medicare: Part A, B, C, and D. Part A covers basically hospital. Part B, about everything else. Part C is also known as Medicare Advantage plans. That's the door number 2. I'll get to that in a second. And Part D, that's Medicare prescription drug plans. So when a person is enrolled in a standalone prescription drug plan, meaning it's not part of another plan, it's just plan purchased all by itself. There are about almost 30 plans available in California that a person can buy. And the selection of that plan depends upon the drugs a person is taking, because all the plans cover drugs differently with different copays, and the plans have different drugs that they cover at the different tier levels. So that's Part D. All right. So what I call door number 1 is Original Medicare. Original Medicare is just a person has their Medicare card. It shows Part A and Part B, the effective date on that or start date on that. And they usually are enrolled in a prescription drug plan, a Part D plan. And in order to cover that 20% gap that Medicare does not cover, they may purchase a Medicare Supplement plan. That's the most flexible, but it's going to have more monthly costs because there's a premium for that drug plan. There's a premium for the Medicare Supplement plan. Versus the door number 2, a Medicare Advantage plan, also Medicare Part C. Those are usually all-in-one plans that include prescription drug coverage, and they are sold by insurance companies. Most of them in LA County are HMO plans, kind of like how Kaiser works, if anyone's got Kaiser or knows folks in Kaiser. So in a Medicare Advantage plan, an HMO plan, you need to have a primary care physician that's designated to be kind of your gatekeeper, who makes referrals to specialists. So in those plans, there's no coverage outside the network. So those plans are the best fit for someone whose doctors are all in one medical group, like Cedars or UCLA, or USC. So there are a bunch of different Medicare Advantage plans that people can get. Most of them are 0 premium per month. So that's the attractive part about them. That's maybe why they're called Advantage, one aspect of it. So they include the drugs, and there may be co-pays for different things, like lab X-ray, MRI, hospitalization. Most plans have very little or low cost for those basic services. But for chemotherapy, for example, one plan might have a fixed copay of $45. Another plan might charge 20% to members for chemotherapy. So the costs for the plan are an important element of consideration when choosing what plan might be the best fit. It's like at Cedars, there are a few plans that are in network with most Cedars doctors. With UCLA this year, there's just one plan that's in network. Every year, these plans change. They run calendar year, January through December, same as the prescription drug plans. So they may cost less on the pocketbook because there's typically no monthly premium. They include the drug plans. You'll pay a copay for those drugs. And you don't need a Medicare Supplement plan. In fact, it's illegal to sell someone enrolled in a Medicare Advantage plan a Medicare Supplement plan. Original Medicare, on the other hand, is the most flexible, but there are more costs involved. For people new to Medicare, there's a 6-month window in which they can get a Medicare Supplement plan without health questions. After that 6-month window, except for some special circumstances, pre-existing conditions can result in a person's application being denied for a Medicare Supplement plan. So once a person is in one, is enrolled in one, they can stay in that, and they can switch to other equal or lesser value plans from any other insurance company in California without health questions. With Medicare Advantage plans, there are no health questions except do you have end-stage renal disease, because there are some special plans for folks with that condition. This is a Medicare Supplement plan chart. Like I said, Medicare is an alphabet soup. So Medicare, 4 parts of Medicare are Part A, Part B, Part C, Part D. Medicare Supplement plans are called Plan A, Plan B, C, D, F, G, K, L, M, and N. So they're an alphabet soup. They all cover more or less many of the same things. I'm not going to go into detail about the differences. Medicare Supplement plans save mention that Plan F is the most comprehensive. It covers the most things. Plan F is going away in the year 2020. Plan G is almost exactly the same. So if a person chooses a Medicare Supplement plan, they have to weigh the cost of the plan versus what things the plan covers. And so it's meant to cover that 20% gap in original Medicare that Medicare Part B does not cover. That's the whole point of these. So a person new to Medicare this year might pay about $170 a month for a Plan F. All the other plans are less. So I don't want to take up too much time talking about Medicare Supplement plans. Standalone prescription drug plans, the deductible might range from $0 to $400 for a standalone plan. What we're going to show you in a minute or so, is looking up drugs using the Medicare.gov Plan Finder, which is a calculator without which it would be impossible to figure out what prescription drug plan is a good fit for someone. It'll also tell you the expected cost for persons' drugs who are enrolled in a Medicare Advantage plan. So because we've got this thing called the donut hole with prescription drug plans, which is going away by 2020. But the donut hole means is that the cost for drugs varies during the year depending upon what a person's total out-of-pocket is. So up on there it says the initial coverage limit is $3,700. So what that means is when the total cost of drugs between what you pay and the insurance company pay combined for a drug, when that reaches $3,700, at that point a person hits the donut hole in which their costs are more. And that goes along until $4,950 is out of your pocket if you're enrolled in a plan. And at that point, you hit the catastrophic level. And drugs are much less expensive then. Then it all resets in January. So what can happen is maybe some folks go along and they hit that out of pocket in December, then the drugs get cheaper, but then it all resets in January. It's also important to review each year, if a person is enrolled in a Medicare Advantage plan or prescription drug plan, what changes have taken place, and to see if they want to make a switch for the next year. Doctors can change. Doctors can exit networks at any time.
Michael, can I ask a question? So many of the neuroendocrine cancer patients are on a somatostatin analog, which is a drug that's injected once a month, and it's given in hospital. So that I just want to point out that for anything administered in hospital, even though it's a drug, it wouldn't fall under Part D.
That's
and that's
right.
a key thing for us, because otherwise we hit that donut hole immediately.
Yeah. There are instances sometimes the insurance company wants the patient to purchase the drug and bring it to the doctor's office, in which case it would be covered under Part D, in which case you'd be paying a whole lot. And sometimes doctors themselves will tell the patient, oh, no, forget that. We'll get it for you. If the doctor's office charges for the drug and it's delivered in the doctor's office or an outpatient or inpatient hospital setting, then it's covered under Part B of Medicare, which is a whole different thing than being covered on a prescription drug plan, which can be really lousy or doesn't exist at all, for certain drugs. So good point. Thanks for mentioning that. Okay, so I was going to go, unless not interested, I was going to go to the Medicare.gov website and just input a couple of drugs and just show you how that works. Is that useful? Okay. All right, so I'm going to back out of here. I'm going to go to, this is Medicare.gov. On the main website, if I click on Find Health and Drug Plans right here, this will bring me into the Medicare Plan Finder. And put in a zip code, and I'm just going to put in 90405. And it asks, how do I get my Medicare coverage? I'm just going to put original Medicare. So right now I'm going to look up the prescription drug plans. It doesn't really matter what you put in here. It's just if you are enrolled in a plan, it will know that and kind of compare it at the end of the process. And down here you have to answer one of these questions. I don't get any extra help. Extra Help is the federal program for lower income people to help pay for prescription drug coverage. So there are asset and income requirements for that. So I just want to get to the, entering the drugs and see what the costs are going to be without the extra help. The next thing is to enter a drug, and I'm going to enter in drug that the client had, your coffee, 15 milligrams, and her particular dosage was 20 pills per month. So Medicare has all these lists of drugs. You click on what the dosage is, click on the quantity, the frequency, the pharmacy type, mail order, add drug and dosage. At this point right here, a drug list ID has been created. So if you copy and paste that, you can always come back to your drug list and edit it or change it or see it. So, there's no having nothing to do with any privacy, because there's no one's name here. This is just a drug list that someone has created, and it's not associated with any particular person. It's just a list of drugs. So you would need the drug list ID and the password date and the zip code. You need to write down or copy and paste those three things in order to get back. Once you got back to this page, you can enter that in there.
Drug requests. Look up.
How you spell that?
Yeah. SANDOSTATIN.
Okay. And
LARDO is the one.
oh, okay. All right. Okay. And 30? Okay. And one per month?
Yeah.
One box per month? Okay. Okay, so now, you can load in these drugs in here, you can edit them, you can delete them. It's all based upon this drug list ID, password date, and the zip code. So then the next step is, after you enter in drugs, you click My Drug List is Complete, and it asks you to select up to 2 retail pharmacies that you might use. Because many drug plans have preferred partners, like Walgreens or Rite Aid or Kroger's or Ralph's. So I'll click on Ocean. I'm just going to add a couple. I'm going to add Rite Aid and Ocean Park Pharmacy. You can only add 2. And you can search for other pharmacies within 3 miles of a zip code you enter if your preferred pharmacy doesn't pop up in there. And this is just a way of like Medicare being able to tell what a drug will cost if you used a certain pharmacy. And so the drugs are in there, the pharmacy's been selected, and then we have to pick, well, what kind of plans are we looking for? Just a standalone prescription drug plan. This is a Medicare Advantage plan. And so I will click these. Medicare plans without drug coverage, that would be a Medicare Advantage plan that does not include the drug coverage because the person gets their drug coverage like through the VA. So they don't need a plan with that. Yeah, so you see it says there's 24 plans in California, 32 Medicare Advantage plans. Continue to results. And this shows the estimated cost just with original Medicare, prescription drug plan, $176,000. If a person was enrolled in with coverage starting June 1st. So this is for 7 months. The plan that Medicare, this is automatically sorted by plan with the lowest estimated cost from enrollment as of June 1st. So SilverScript choice for this combination of drugs and dosages comes up, the cost as of today for the 7 months, $10,386. That includes the cost of the drugs, the plan premium, and any deductible. This plan happens not to have a deductible. The next one, which is close, SilverScript Plus. Notice the monthly premium on this one is $83.70. This one's $29.90. The monthly premium by itself or the cost of drugs by itself aren't important by themselves because it's everything all together that kind of determines what a person's out-of-pocket would be, for the whole year from the time they're enrolled. So a monthly premium might be a lot more, but for those drugs, apparently the cost of drugs under the costlier plan is a lower copay. So it ends up costing a little bit more by about $290. Yes?
I notice in the far left column that the cost, or in either of those categories, or for the different companies, the cost would be $10,386, but the mail order would be $13,977. I thought the whole purpose of doing mail order prescriptions was so that it would be less money. I'm curious as to why the mail order's cost is
higher. We'll see. We're going to drill down a little bit farther. Some drugs, mail order is more expensive than at the retail pharmacy.
So really, as a consumer, you really need to do your research per drug and look and not just assume overall that the mail order is going to be less expensive.
And there may be other places besides the prescription drug plan where a person can get drugs for the same cost, maybe lesser cost, by looking at some other resources for prescription drugs or Canadian pharmacies, for example. So some people look, if I get a drug through CanadaPharmacy.com, they send a prescription from their doctor, and that's mail order. So some people find that it's less expensive. So looking at all the drug lists, there may be a certain drug that is maybe less expensive to obtain outside of a prescription drug plan. It won't count towards hitting that kind of out-of-pocket, getting to the catastrophic level then. So it's just an additional moving part. Something to compare this SilverScript choice. I'm going to click the box for this. You can compare up to 3 plans. The next one that's listed with lowest estimated cost, Envision Plus. So I'm just going to compare these first 2. Going across here, I just want to mention that overall star rating. Medicare gives a star rating to plans. And if you click on the little star, it says, what's that about? It's a whole bunch of different categories, including customer experience, available of drugs, changing of the drugs, accuracy of drug pricing. So, you know, the rating by Medicare overall gives, I mean, all things being equal, you'd want to go with a higher rated plan because there are less problems with that plan probably in different areas. Okay, back to the plan. So the Silver Script plan is 4 out of 5 stars rating. So I've clicked those 2 plans, and at the top here, a little brown thing, compare plans. So then I'll put up the plans side by side. And Giovanna, what time did I start? And I should like wrap it up after half an hour, right?
Yeah, maybe like 5 minutes.
5 minutes? Okay.
Is that doable?
Yeah. Yeah. So here are the 2 side-by-side plans. Gives information on contact information about the plans. The premium, drug deductibles, estimate of what you will pay, including the premium, any deductible, which there are none for these plans, and the cost of drugs at these different pharmacies that were put in there. So you can see it's, you know, the pharmacy hardly makes much difference. And so we're going to go down, drill down, why is mail order different for some of these drugs? Now as I scroll down, it says, well, what is the monthly cost at these 2 pharmacies? In the first month, the cost is $3,479. So a person hits, it says catastrophic met. So then the drug costs after that month 1 go down to $1,100 a month after that. And that's pretty much where they stay, you know, on this plan. Down here it shows what drugs are covered by the plan's formulary, the list of drugs, and what's required. Are there any special requirements for the drugs, like prior authorization, you know, quantity limits? What tier is it? So sandostatin is a tier 5 specialty tier, so it's more expensive, and so is Revlimid. So under the estimated drug cost, let's see. Here we go. View monthly drug cost details by selected drug. So here's, so you click and it brings up a new window and it shows what is the cost of these drugs up at the top at the 2 pharmacies, then plus mail order. So we can look, and you can print out these things too. So it shows what the cost of the drugs is. Here's the cost of month 2, you know, broken down. Your cost and what the total drug cost is. So the total drug cost of Revlimid, you know, is $12,770. Your cost is $638. I'm going to go to, so just kind of remember these amounts. For the sandostatin, your cost is $282, and for the Revlimid, $689 at the pharmacy. And if I go to mail order, look, Revlimid is $1,800 mail order, and sandostatin. Well, there's apparently no pharmacy benefit manager who is selling these things or using these things via mail order. So mail order isn't necessarily less expensive. For drugs that are like tier 1, 2, 3 and on the formulary, usually is, it's less expensive. Now, for drugs, there's different things. I want to just wrap up and let Martine start digging in a few minutes. But although drug costs are set in the drug plan's formulary and described in the benefits for each plan, you can request changes to the drugs. And you can also request a drug that is not in the formulary to be covered, called Formulary Exception. You can ask for these things. You can ask for them by phone, in writing, you know, to the plan. You can ask for a tiering exception, where if a drug is a tier 4 drug, for example, you can ask for it to be covered at a tier 3 cost. So you can ask for these things. Sometimes the plan will say you have to use step therapy, meaning you try this generic drug before you get to use the drug your doctor says you need. Now, a doctor can request the formulary exception to remove that step therapy on that. So you can ask for these things. If they say no, you can appeal that decision. You can keep appealing this stuff all, up to a high level to, basically, judicial hearings. And that's probably something that Martine is going to cover. I'm going to force quit that, let Martine come up and do her stuff. The handouts that were handed out, there's some of the resources I used and some of the things discussed during the presentation. If you'd have questions, you're welcome to contact me, send me an email about these things. I'm happy to give you my 2 cents and help whatever I can. There we go.
Well, thank you, Michael. Thank you
You're
very
welcome.
much. So that was a great presentation. There's a couple of things I think are really particular for neuroendocrine cancer patients, and one is to just make sure people know that they can apply for Medicare even if they're not 65 by getting Social Security disability. And I think
That's
you mentioned
right,
that
yeah.
at the beginning.
Yeah.
That may be really important for some patients who get diagnosed, wind up having surgery, having other treatments, so now they're not working, and Medicare can then kick in and cover your bills for you. And the other thing is that since most neuroendocrine patients are on either sandostatin or lanreotide, this is a very, very expensive drug, and it's most of the time administered in the hospital because it's either a deep sub-Q or IM shot. So, and if it's administered in the hospital and you're on Medicare, then you never get into the Plan D part of Medicare because it's not a separate drug. It's being given in the hospital. Like, we have a couple of patients who their wife is a nurse, so they have it sent to them. But if you do it that way, then you'll have then you wind up in the donut hole and paying for it as a separate drug. If it's given to you in the hospital by the nurse, then it never gets to Plan D.
Yeah.
It's because it's in the hospital.
Unless you buy it and bring it to the nurse.
Which you probably don't want to do,
You don't
right?
want to do, yeah.
right.
If you can all
Unless
avoid
you
that.
just want to start
And
paying.
on that reference sheet, I just want to mention the cost of drugs. There's a website, goodrx.com, that will give you street prices for drugs. And they also have some resources. There are some patient assistant programs that help lower the cost of drugs. There's information on that website, and that's on that resources page. I just want to mention that.
In the case of these monthly injections, which people will be on for life, so it really adds up. Some hospitals are billing over $50,000 a month, so it's not a really affordable type of thing. Now, they're not getting reimbursed that amount, but that's what they're billing.
Yeah.
So. Well, thank you so much. That was excellent.
You're
I hope
welcome.
you can stay for some
I will.
questions. So, as Michael mentioned, you may decide that you want to appeal or you need some more help if something has not been covered. So we'd like to welcome our next guest, which is Martine Bruce. She is a healthcare industry expert with over 2 decades of medical billing experience, and she's the founder of Advamed Pro, a patient advocacy company based right here in Culver City. Her extensive experience as a billing manager and insider knowledge from coding to appeals, she helps clients audit accounts, lower medical bills, resolve insurance payment issues, and defend their rights. This is somebody we really need on our side. Martine is a certified mediator and has negotiated hundreds of financial agreements on behalf of providers, patients, and insurance companies. She gets results through negotiation skills, understanding the legal options, and outside-the-box thinking. Martine blogs and lectures on managing the cost of medical care, and we're very, very fortunate to have her right here with us today. Welcome, Martine. Thank you.
Thank you. I was a billing manager for 20 plus years, the last 6 running an oncology practice, busy oncology practice in Santa Monica before I decided to turn to the side of patients and use my knowledge to get them the peace of mind that they should be having, rather than having to fight insurance companies and wonder why on earth am I getting this bill now. So hopefully getting a little closer to there. I cannot promise peace of mind, but my job, as I see it, is not only to tell you that you have rights, you have options, but then also that people like me are out there. We are not many. The public doesn't know much about us, but we are here to take the financial burden off your back so you can focus on your recovery and on your health. So the slides will be forwarded, I guess, to each participant. So, right. Yes, I'm sorry. Okay, so this is for today. I want to give you some tips to ensure maximum reimbursement before, during, and after. Then we'll navigate some denials and delays. I will give you some information that I think you might find helpful. Cost reduction tips from the side of being a billing manager. I can tell you what works, what would be acceptable, and what may not. I've also given you a list of some resources of where you can turn when you feel that you are banging your head against a wall, or that you have, you feel that you have not gotten any kind of response or any kind of assistance. And then we'll have a question and answer session. So my policy or my way of seeing things is do it right the first time, or spend more time at the beginning when you can still catch things before they grow, before the snowball grows into a huge destructive boulder-like. So we have different types of coverage. I've listed here 3: HMOs, PPOs, and Medicare. The difference is something you must know. That's the most, if you know anything about your policy, look at your insurance card. It will tell you you have an HMO, a PPO, or Medicare, either straight Medicare, original Medicare, or Medicare Advantage. That is of the most importance for you. It will determine where you go to get treatment. It will determine what are the steps you need to do in order to get to the doctor that you need to see. It also will determine how you can fight an insurance company if you need to go, let's say, out of network. What is the process to get there? An HMO is Kaiser, to take an example that I think a lot of people are familiar with. It's basically a medical group, a group of doctors. They provide all the care for you. On one hand, it's usually at a lower cost for you. On another hand, you give up some of your freedom of choice in order to get centralized care and in order to get sometimes lower cost. So the problem with HMOs is every time you take a breath, you are going to need a referral or an authorization. The process is tedious. The industry hates HMOs. As a billing manager, I can tell you, I mean, I'm probably coloring half of my hair because of HMOs. However, you know, it is what it is. Sometimes you don't have a choice. This is where the coverage you get through work or that you can afford, but you have ways of maximizing the reimbursement. So the referral process goes through your PCP. Your primary care physician is the one that you go to and who will direct you to different specialists who will order test labs, imaging, and things like that. I suggest if you have an extra box of chocolate somewhere and don't want to eat it, go find the person at your PCP's office who is in charge of getting the referral process going. I can tell you it makes the difference between you having to knock on doors, having to complain, having to cry over it, and having somebody right there who says, "Oh, of course I remember you. Let me get that done for you." I have a patient like this. He's been trying for almost a year to get an authorization for an out-of-network provider. I just got to the person who is keying the stuff in, had a nice, lovely chat with her for 20 minutes, and I got my authorizations. Yes. The person would be in the, when you go to your PCP or if you call the receptionist, ask for the name of the person who handles the referral process. It's called also the UM department, Utilization Management. Sometimes a medical group will have one that supervises or that manages the referral process for a number of physicians. Basically, that's the name of the person you want. That's who you need to make very good friends with. Your policy should state what your liability is, and it should also tell you what your coverage and your benefits are. If you do not know, there should be an 800 number, or you can go online and check that information. Whenever your physician orders a new drug, or whenever your physician orders a treatment, it might be a good idea to go and check the policy. Specialists and out-of-network services are available. It is a myth that even Kaiser will not send you out or will not pay for that. I ran an oncology practice and I was seeing Kaiser patients. The problem is it's going to be a tedious process, and you are going to have to file a grievance or file an appeal once the original referral is denied, because it will be denied. And unless you can prove that the specialist that you require is not available within the HMO network, or if you can show that you have tried to go see the specialist that was offered through the network, but you are either dissatisfied or that specialist cannot help, then you can go out of network. Second opinions consults can also be out of network. I used to book them. I mean, some providers have special contracts with Kaiser, for example, or with other HMOs. Again, it depends on how large your network is, your medical group is, but the PCP's office should give you the process on how to file an appeal, and the response should be pretty quick. And I'll give you some other ways of, or some other advice on that a little bit later on. PPOs can be Medicare Advantage or commercial meaning non-Medicare. The process is easier in the sense that most of the time you do not need a pre-authorization or a referral. It all means the same thing. It only is usually required in case you get chemotherapy, or unless you get some type of surgical intervention. So your doctor's office should make sure to contact the insurance company and ask. Even if an insurance company states you don't need a pre-authorization, let's say for a chemotherapy regimen, that's really nice, but have them do a pre-review. A pre-review is basically the doctor's office will send to the insurance company the plan of treatment and will ask the insurance company to determine whether or not you are covered, the benefits are available, and how much your share of cost would be. So what you get in response, and again, the turnaround is very quick. What you get in response is your insurance saying, yes, we agree that this course of treatment is medically necessary. Yes, we have reviewed the chemotherapy orders and everything is covered, and we anticipate the share of cost to be that much. And so you don't have a guarantee the same way you would have if you have an authorization, but at least you have an advance notification that can, make your life a little bit easier, not having to worry what's going to happen, if I start and I don't know what's going to happen. So Anthem, especially if you have Anthem, pre-reviews are readily available. They take, I think, 3 days turnaround, just about. And I greatly encourage you to, to do that. Yes.
I'm about ready to have a procedure.
Okay.
I'm Medicare and I'm Anthem.
Okay.
So my question to you is, would they be equal? Would a pre-review and then after the procedure what was covered and I get the bill, would they be equal?
They're not. You have Medicare. You don't need a pre-review. Unless you have an HMO plan.
No.
You have a
PPO.
PPO plan. Did you have one done within the last 5 years?
No.
Then if you're over 50, it should be covered under Medicare and, therefore under your plan. However, again, it would be, because it's outpatient, it's a simple, procedure. I can guarantee you do not require pre-authorization. In that case, what I would just do is maybe call Anthem, call the 800 number, and ask them to calculate your liability. They will be able to tell you how much of a deductible, how much out of pocket you have already met for this year. You can also verify that the facility where services are about to be rendered are in network. That will lower your cost significantly. And they can then give you an idea of how much you can expect to be responsible for, if anything.
And that's called a pre?
That would not, the pre-review goes through the utilization management, and this you would not. You would just call customer service.
Just the customers.
Absolutely.
And ask for pre-review.
And you say that you have this colonoscopy scheduled at that facility. Can you please let me know what the cost would be, whether or not the facility is in network, and what might be any kind of requirements. Usually they're not. Colonoscopies don't
Thank you
have
so
requirements.
much.
Anyway, when you go see a provider, that's the thing with PPOs is that when you go within the network, your cost will be lower. You get adjustments even if you have not met your deductible yet. You will still get some kind of a discount based on an agreement between the provider and the insurance company. It is to your best advantage to go to in-network providers. If you cannot, or let's say, the one specialist that you really need to go see does not take your insurance or is not covered, you have ways to request an exemption based on the fact that the medical necessity of the request, and based on the fact that your insurance does not offer any similar or any equivalent specialist within your network. For straight Medicare, I'm gonna pass over that because we went over it. But I just want to make you aware of a form that is called the ABN. The ABN is a specific form that sometimes you may be asked to sign. It should list what services might not be covered under Medicare, and it should definitely list the estimation of cost. It has ABC for you to choose from. A would mean that you are aware that the cost may be yours because they might not be coverage, but you still want the provider to bill Medicare and see what happens. The second is you don't want Medicare to be billed at all and you will take care of the bill. And the third is you don't want the treatment at all because you've just been told it might not be covered. When you sign that, the provider will send the claim usually to Medicare with a little modifier, 2 letters, and those letters are going to change whether or not, if a service is denied, whether or not you get billed for it or whether or not the provider is obligated to write it off. So beware when you sign an ABN. If you do, ask, why do I have to sign it? Why is Medicare not covering it? That's my question. Have you been explained exactly why is it? Is the treatment off-label, meaning it's not FDA approved? Or is it something that doesn't fall within the requirements of coverage per Medicare? And if not, why not? So,
I have a question.
yes.
So regarding the PPO with
Yes.
out of network,
Yes.
what if you just have a doctor you would prefer to see? You mentioned a grievance.
Yes.
Like, for example, and this is low level, but I have a particular chiropractor.
Yes.
That I would rather go see this chiropractor than try someone new, but they're not in my network, even though they accept my insurance. Is that really a grievance?
Personal choice? No. You
Oh.
have almost no chance.
Okay.
You would have to explain that you went through every other one in the list, and I had a client who did that. We did that. It was just for breast cancer reconstruction. One office was not really, it didn't look very clean. Another one hadn't done that type of procedure in more than 10 years. You know what I mean? So we went to Anthem, and we explained that we did interview every doctor. However, each one, there was something, one was not board certified, and I don't care what you find. You know what I mean? You're going to find something that you don't like. And that's why we wanted to go to this out-of-network provider. And it got approved. Yes. Another thing is they are something I've used successfully with UCLA to get something done at UCLA when UCLA was out of network. I won with a state when I did that, is to prove that the plan is in violation of California licensing law because according to, and trust me, I read all of that. If you have insomnia, I mean, that's a great way to get rid of it, I swear. The licensing of insurance plans in California requires an insurance company to have a certain number of in-network providers within a certain distance of geographical area. So if you can show that, there's nobody within 30, usually it's 30 miles, even though like when I won that case, it was like 5 miles. But if you can show that you have nobody else within a geographical area or that your choice is so limited that let's say you only have 1 or 2 choices and these doctors cannot see you right away because they're too busy or because they're on vacation or God knows what, then you can get exemptions.
As a follow-up to that question?
Yes.
How do you, is there a website that shows an insurance company's in-network
Yes.
providers?
Your insurance, you can, and this I recommend to anybody regardless of, create an online account because you can see your claims, you can see your coverage, you can see, how much deductible you have met, you can find providers within a network. And so you put your zip code. I mean, once you sign in, it will know who you are. It will know your plan. It will know your zip code. And then you can choose, find a chiropractor or find whatever, a specialist. And usually I would say, put 30 miles at most. You can even put less. And then you will get a list of contracted providers with that specialty. You can even choose, like if you want, male or female doctor, you can choose, a different zip code. If let's say you don't, you work in a different zip code, then it's easier for you to go to a doctor, near work on your lunch hour rather than, close to home, and it will give you a list. And from that list, some lists are really very extensive. Some lists, you're just going to find 1 or 2 names at best. And again, if a doctor cannot, and I have a slide for you, if a doctor cannot give you an appointment without a specific amount of time, that's a violation of California, again, licensing law. Therefore, you can appeal and say that, you tried, but your hands were tied.
Before I had Medicare,
Yep.
I'm a retired state teacher,
Yeah.
so I have pretty good insurance for now.
Yeah.
Okay. Before I had this insurance, I had an eye surgery, 2 of them at UCLA.
Yeah.
And I also had some surgery at Cedars. The codes were impossible to read. And my question to you, I don't know if you'll answer this or not. I'm asking you this with full respect, by the way. I was told by an attorney that insurance coders and billing offices go to school to learn how
Yeah.
to make it complicated.
No.
For the
Actually, they don't make it complicated. All the codes are determined by the federal government, CMS. It's not
Federal
something
government?
that billers or coders take out of, the top of their heads.
But
You
they
go
can
to school
manipulate
to
them.
learn it. No. Actually, when you become like a certified coder, whatnot, you have to abide by certain ethical rules. Okay, but some people are ignorant or some people are not well trained. Fine. However, you have to, according to federal law, CMS law, you have to code according to the highest degree of accuracy based on medical records. And there are ways, you cannot code something one way or another. You cannot bill one amount to one person and bill the same thing to another insurance company at a different price. They're really a set of very strict guidelines as to how you must code. And if you want to look at them, all the rules are, under CMS. I mean, you can, you have to deal with modifiers, which are 2 letters or 2 numbers that may explain the procedure code, better. You have to, they're very strict rules. Otherwise, your claims cannot be processed. Otherwise, the claims will be rejected as information is not correct, or it's inconsistent, or it's missing, or whatnot. So you go to school actually to learn how the process works and how to determine how to bill and therefore get paid for a service, a supply, a procedure. Otherwise, so you cannot just pick and choose whatever you want. Like even let's say you go for an office visit, right? Established patient, you go for a follow-up. 5 codes. Well, you can't just pick up the highest code, which technically will get you the same amount of money, right? It depends who you see, what for, how long, what was the degree of decision making, things like that. And so a coder will have to look at the medical records and see what the doctor wrote. And the doctor will write, I've seen the patient for 15 minutes, or I saw the patient for 45 minutes. That will make a difference in the code. Because the doctor has, under Medicare rules, and Medicare rules, one rule rules them all, they will tell you that, you have to use a 99212 or a 99214, depending on the amount of time, or depending on the severity of the decision making, or depending on the level of care that is given. You can go, for example, just see a nurse, right, to get your your labs drawn or something like this. They cannot bill what an MD bills for. I don't care if you stay with them for an hour. They cannot. They have to bill 99211, get paid $20, and that's it. Call it a day. Even though they are there for an hour or 2 hours, doesn't matter. However, an MD is a range. If you are a cancer patient, automatically by rules, everything is 99215, the highest level, because of the severity of a case and because of the highest degree of decision making. So you may think that you only saw the doctor for 5 minutes to get a prescription refill. However, he has to bill at that highest level because, again, of your diagnosis.
cancer. And what were those codes for cancer patients?
99215 for the MD. He can bill less if he wants to. However, according to the regulations, he can bill up to 99215 every time he sees you, as long as you have a diagnosis. A nurse is 99211. So during treatments, whatnot, just make sure that any new provider or any new service that comes your way is established as being in-network or requiring or not some kind of authorization. Again, I hope for you that your PCP or your, the physician who takes care of you has a staff that is trained and caring enough to do this for you. Technically, you shouldn't have. I mean, when I ran a practice, my patients never had to do that. I did that for them. However, a lot of offices are understaffed, overwhelmed, and you may have to check, at least ask, did you get that for me, or do I need that? Out-of-network access, medical necessity rules, and we'll get back to the definition of medical necessity, but again, everything is possible. You can file appeals and you can file exemptions requests. Afterwards, or check your explanation of benefits for obvious errors. For example, you went on the website, you saw that Cedars-Sinai was listed as a contracted provider. And by the way, anytime you go check if somebody is a contracted provider, please make a printout of that screen, because things change on a monthly basis. But if you go when a provider is listed, even if you're in the middle of treatment, the insurance then will have to cover you at the higher rate, even if that provider terminates their contracts. So, but you will need proof. Compare your bills with the EOBs. If the amount that you're being billed for does not match the responsibility or the liability as listed on your explanation of benefit, ask questions. And again, investigate denials, rejections, all of that. Why errors happen. Sometimes it takes just a code that is incorrect. Sometimes it just takes, that, again, a provider switched tax ID number. Sometimes it happens, honestly, and sometimes it's so easy to correct one code rather than having to file an appeal for something that cannot be paid because the diagnosis does not match the procedure code. For example, let's say you're getting Neulasta or Neupogen. Well, if you bill it with a cancer diagnosis, it's going to be denied. It's not a cancer drug. No matter, you can appeal 10 times. Yes, it was medically necessary. You can go with your labs. The diagnosis does not match the reason why the drug was actually given. You have, California law is for urgent access to care, if you do not need a referral, such as in a PPO and Medicare Advantage plan, 48 hours to get access to care. So this is important because if you do need to see a specialist and the only available is out of network, you can use that to state, well, I cannot wait another month for the in-network doctor to give me an appointment. Because that again shows that the network that is provided to you by this insurance company is not wide enough and may again violate licensing laws. Urgent 96 hours for the need for a referral. That's an HMO. If after 96 hours you have not received your referral, well, hopefully, call 911 or go to urgent care if really you need to, but otherwise that is also something that could be a violation. Non-urgent is 10 days to see a PCP, 15 to see a specialist or get a scan or a test or something like that. Emergency services are usually covered at the in-network rate, especially if you have a plan that was issued after January 1st, 2010, that fall under Obamacare. And there's a little-known law in California that states that any authorized service must be paid even if the insurance company realizes after the fact that they made a mistake. If you get something authorized, the insurance made a mistake that only realizes after the fact, they have the obligation to cover the cost. Even if it's not in your policy, even if it's an exception in your policy. They made the mistake, they have to pay for it. Continuation of care might apply in cases where you start treatment with at an office, they decide halfway through that they are going to cancel their contract. You must continue, and changing to a different office may delay, may stop your treatment, that would be harmful to you. There's usually a clause in policies that state that continuation of care will be covered and the insurance company will be forced to continue paying for this course of treatment until its completion with that physician, even though he may not be in network anymore. So even if they are trying to force you to go somewhere in network, they actually don't have a legal standing to do so if you are in the middle of treatment. When you are requesting treatment authorization, you are requesting an out-of-network consultation. If the first answer is no, again, first thing you need to do is appeal. You would appeal with documentation showing, again, you cannot get an appointment fast enough. There are no specialists within the network that can, accommodate your need. You would have to travel for, 50 miles, and, you couldn't do that. So you appeal right away. The authorization process usually takes about 5 days for a response. Then a peer-to-peer review can be obtained with any insurance company. That means that the physician who orders that service, that consultation, that test, or whatnot, can speak with the insurance medical staff and try and explain the rationale why you must receive that service, why that authorization must be given. So there's actually more than just medical records. There's two physicians talking to each other about your specific case and why it goes outside of the norms. The HMO, if the medical group denies, goes straight to your HMO. For example, if you are, with a UCLA IPA and you have Anthem, go to Anthem. They are usually more prompt to give authorization. The California Department of Managed Care has an independent review process. I give you the direct link there. If you have a denial, even if you don't want to go to the peer-to-peer review, if you just have a denial and you filed an appeal that was denied as well, go to the state. You can submit the medical records. They have independent doctors who are not paid by your insurance company, who will review your case, review your medical records, and issue a decision usually within 3 days to 5 days. And their decision will force or may force the insurance company to cover a treatment. I was just on the website this morning. Right now, the rate, the first time you apply for treatment, the state has approved about 60% of them right offhand. I think there's about 20% additional where the documentation submitted was insufficient, so it was ruled against the patient, but just again because the case was not strong enough. So the state is actually on your side, and I would strongly recommend that rather than, fighting, let's say, an HMO longer than you have to, go to the state. Their decisions are legally binding, and most of the time they are given 5 days to comply. And trust me, nobody, as any insurance company, likes the state of California. They are very, very, very strict. Medical necessity, we've been talking about it a lot. It is not because it's ordered by a physician. That is a common mistake. It's not medically necessary as far as your insurance is concerned, as far as the state of California is concerned, as far as CMS is concerned. It is not just because it's ordered by a physician. Standard and established protocol means that the American Medical Association, the FDA, CMS, which is Medicare, HHS, or your peer community have declared that this specific treatment, this specific regimen is actually appropriate. So it is necessary for the cure, maintenance, or avoidance of a condition, and not receiving it would prevent, delay, or reverse progress, negatively impact the patient's well-being. This is what you must prove whenever you file an appeal for medical necessity. It is not enough to just say the doctor ordered it. And the doctor has to have in his notes why he has come to the conclusion that this is the best option or the best course of action for you. So you may have to, go and do some research. And again, I hope that the office of a doctor who is treating you does that for you. That's their job. But in case you have to, that's what the standards for medical necessity is. It's journals, it's, standards as established by governing or agencies. Okay, speak loud.
So, what this brings up for me, I was diagnosed with breast cancer at the age of 38, and what I keep hearing from other women that are not yet 40 is that they feel like they need to get a mammogram. They want to get a mammogram because standard age for mammogram is 40. That sometimes their doctor says, oh, well, you're not going to get it approved, so don't worry about it. And another woman that I know needed to get a colonoscopy, but because she didn't have colon cancer in her family, she was denied and had to pay $4,000 out of pocket. It turned out by the time she was able to get the money, it had progressed to stage 4. So, because she was so young, for young people who don't fall into the protocol, how do you get these? Like, what do I say to a girlfriend who's 35 years old that feels like she needs to get a mammogram?
Okay. The question is if there is no family or personal history, then there must be symptoms. If you just do it because you want the peace of mind, if you just want to do it because, whatnot, that's not medical necessity. That's a personal choice. And you cannot, I don't know how you're going to be able to, get that covered. If you have what happened to an acquaintance of mine, she really had that feeling there was something wrong, but she didn't really have, she didn't have a history and whatnot. And and in the end, she decided she paid for it herself. And yes, she also was diagnosed. However, because she didn't have symptoms, her physician had nothing to go by. It was too early, but yet she was lucky to have it caught so early. She only was stage 1. However, that is not medical necessity. So with symptoms, yes, definitely. So medical necessity is really important if you're going to file an appeal or, make sure that it's not just what the doctor ordered. Lack of referral is also one of the main reasons why things are denied, either because the insurance gave incorrect information, that happens a lot, but you have options. First is if it's caught early enough, you can get a retroactive one or you can amend one. For example, I just got an authorization for a PET scan for a leukemia patient. Well, what happened is that the provider put in the wrong code because PET scans have, a variety of codes. So rather than getting a new one and going to Anthem to the director of the utilization management and ask for another favor, all that I needed to do was just change the code on the piece of paper. That's it. I have another patient, an HMO patient. He's out of network. Visits to a specialist. He had 12. His authorization only approved 3. All I did was, rather than fight, was to, call my best friend at that PCP's office and ask her, can you please change from 3 to 12, which she did while I was on the phone, and everything got covered. So does the info match? Sometimes, your doctor may think that they're going to be doing a procedure at this hospital, but there are no, available times, so they go to the hospital across the street. Well, that's really nice, but the authorization is for the first place. So you should always be receiving a copy of that authorization. If you do not, request one from the office, and just make sure that the date range is going to be during which you're going to have that procedure done. If you're going, you can't get off work for, 5 weeks and the authorization ends at the end of a month, well, amend the authorization beforehand. The referral number must be indicated on the claim form. There's no way for you to know that it was not, except that you will receive an explanation of benefit telling you that there's no authorization. If you know for sure there was one, call that billing office and tell them, did you put it on the claim form? And it's an easy corrected claim with an authorization number, it will get paid. So you don't need to file appeals on all of those. These are just like technical errors that can be resolved really quickly. If a medical group denies an appeal, go to the health plan. That is your right. Whoever you're paying your premiums to, you're paying your premiums to Anthem or to Blue Shield or to Aetna. You're not paying your premiums to UCLA Medical Group or to Cedars-Sinai Medical Group. The people who are taking your money are the people who are supposed to get all of that done on your behalf. And so that's the people you go complain to when your medical group is not cooperative with you. Out-of-network processing, that happens a lot. ER services must be covered again under Obamacare if you have a plan that is neither grandfathered nor straight Medicare nor falling as self-funded. And out-of-network providers must pay at the higher rate at contracted facility. How many of you have had anesthesia claims paid out of network at an in-network facility? Well. The system recognizes a tax ID number, says, oops, that's not one of ours, and we'll pay at the lower rate. Well, I can tell you I did anesthesia billing for 14 years. That is an error that is very easily corrected by a phone call to your insurance company to tell them, look at the facility, look at the hospital. The hospital is in network. That means any and all providers, any and all services rendered at an in-network facility that you did not specifically hire for, right, must be covered at the higher rate. There's 4 conditions to cover that. It's, again, you did not choose the provider. You did not have a choice. It's medically necessary. You're not going to bite on a piece of wood. I mean, let's face it. It was the only option at that hospital. Therefore, the insurance will cover it at the in-network rate. Okay, medical necessity, again, we talked about that. And we talked about the lack of qualified in-network providers. Investigational, experimental, this will have to go back to your doctor's office. They will have to explain, or your physician will have to explain why something was ordered that does not fall within the bounds of medical ethics or whatnot. However, sometimes, again, things are coded incorrectly with a wrong diagnosis. That happens a lot, unfortunately. Cost. And again, all of these slides are going to get to you. But basically, ask questions. There are less costly alternatives, and I will throw 1 or 2 at you. We talked about the different Medicare levels. It goes the same way for commercial. Whatever may be covered under your medical expense, for example, things done in office or things done at the hospital may be cheaper if you do it at home. You're getting, for example, let's say you're getting B12 injections. You go to the office, not only do you have to pay for parking and sit there with sick people, do it at home, home health. It's going to cost you, it's 10 cents for the B12. So the nurse coming to your home is going to cost your insurance a lot less. So it's going to be more work for your physician because they have to arrange for that. However, it may be a good thing to ask, do I have to come to the office or can that be done somewhere else? Same thing with Neupogen. You're getting Neupogen, you're going to the office every day. Well, maybe if you're getting at least 9 doses, you can ask for Neulasta instead, 1 dose. Or you can ask for a prescription to do it at home. It's a pre-filled syringe, very easy to self-inject. The nurse can show you how to do it. And it's usually, or it might be cheaper for you to do it at home than to do it through the office. So that's why I'm saying, always ask. Is there an alternative? If there's no alternative to Neupogen or Neulasta, well, you know what? The alternative would be the place of service. Already you're going to save money on parking. Donation programs, copay assistance card, whatnot. These are really useful. Ask about the cash cost too, like for example, Costco. Go to Costco.com. You don't need to be a member to get to their pharmacy. They have really, really preferential cash prices. Make friends with people at the office, the billing manager, again, the person who does your authorizations. And when you negotiate, these are some ideas. Sorry, I'm always like going over.
We want to make sure we have some time for questions.
Yes.
So,
And,
and
okay.
we'll be happy to share all your slides.
Yes, there's just one last thing is that for prescription drugs, there's one company that you may want to try. They are called TNH. They have actually staff members who will calculate the cost to you, will call you, ask you if you actually want the prescription, or if you want them to find financial assistance to cover some of the cost of the drugs. They are aware of every, assistance program out there, and so they do the work for you. But your physicians will have to send the prescription to them. Another one that kind of works like that is US Bioservices.
Martina, I wanted to go back to one of your slides, which
Yes.
was about the investigational and experimental,
Yes.
and also off-label. As neuroendocrine patients, we have a lot of all three of those.
Yes.
And we're fortunate now that we have a lot of newly approved or pending FDA approval drugs, treatments, scans.
Yeah.
So you've made us realize that how important it is that these then become incorporated into the guidelines, because once they're in the guidelines, then they do become protocol.
Well, that's right.
Standard.
Technically, if it's approved by the FDA, then Medicare approves it, right? And then commercial insurance too. However, sometimes you don't see it as being covered right away for one reason, is that there's no contract yet to get the drug at a lower cost. And I've seen that, a couple of times when I was a billing manager. It's like I'm trying to get something approved, and the insurance is telling me I cannot approve it because it's not in the system yet, in the sense it hasn't been established with a code, with whatnot. Another time is when you're using a protocol and it is something that is covered. However, the frequency or the dosage differ from the indication. In that case, it's off-label. Or it could be that, for example, I had like a couple of really obese, very, super duper obese patients who needed a much larger dose. However, it went against, it was counter-indicated as far as the manufacturer and the FDA were concerned. So we had to get a special approval for that. So then the medical necessity would be basically the weight of the patient, and some insurance companies will take it, some don't. Sometimes you have to give a reduced, like Medicare will not go over. They have limits, and you can check that online. And it doesn't matter if you're obese and if maybe it's not going to work as well. That's the way it is.
Great. Well, thank you so much for joining us today, and we will share Martine's contact information. She is right here in Culver City and does consultations for your individual needs. And thank you all for coming today, and thank you for your joining us online today. We want to thank Tower Cancer Research Foundation once again, and Michael Gradski. Come on up, Michael. Thank you both so much for being here. This is a very important issue, and as you know, if you've been diagnosed, that's enough already. And so on top of it, having some help navigating these billing issues is really important. So thank you, Michael and Martine, for being here.